Welcome to Long-Term Oxygen Therapy Assessment Process. A reminder, Session 3 of the Oxygen Masterclass. This is a live recording of a webinar presented by Kath Plumbe, Clinical Oxygen Transition Lead and Consultant Physiotherapist at Respiratory.
Hi everybody, you're back now with Kath Plumbe. I'm the Clinical Oxygen Transition Lead, which basically means I work 1 day a week for the South East Coast PCT Alliance to provide support to the oxygen team regarding the transition from the old to the new contract. I will be talking through the long-term oxygen assessment process, and my session will be slightly more interactive than the previous sessions. You will find that we are working through case studies, and at those points I will be asking you to answer some questions. I will make sure I give you plenty of time to look at the case study before I ask you for your decisions, so that you do have the opportunity to be fully interactive with the session. So we're going to talk through the long-term oxygen assessment process and then work through some case study examples to highlight some of the points that we've discussed this afternoon. So to start with, the initial assessment. So this is the assessment before we even get to the stage of conducting arterial blood gases. So this is when we are simply measuring oxygen saturations via a pulse oximeter. And we know that in reality this happens in many different situations. It might be measured in a GP surgery, it might be measured at home via a district nurse or community matron, or perhaps a specialist community respiratory team. It might be in an outpatient clinic, or it might be in pulmonary rehab. There are many situations in which this initial assessment can take place. And this is where we're looking at the oxygen saturations being above 92% to be considered good enough to be actually not requiring a full oxygen assessment. Once you have taken these saturations, you then need to have a look if they're below 92%, and if they are, refer on to your HOS-AR service or equivalent. At this point, this is when we recommend that spirometry should be performed if it hasn't been recently, and we do need to make sure at this stage that people have a confirmed diagnosis. If we don't know the reason why somebody is hypoxemic, then we need to, before we move on to initiating oxygen. Once a patient has been referred onto a HOS-AR clinic, so these are the specialist respiratory clinics that many of you will be involved in, or many of you will hopefully have available to you soon. So this is when either arterial blood gases or capillary blood gases will be taken. So patients come into the clinic after they've had their assessment and have rested for 30 minutes. Their oxygen saturations will again be taken to confirm that they are above or below 92%. Obviously at this stage, if they are below 92%, then we would move forward with an arterial blood gas. And we'll be looking for levels for their PA2 to be less than 7.3 kilopascals or less than 8 kilopascals if they have other conditions as well as respiratory disease. So things like peripheral edema, polycythemia, pulmonary hypertension. And again, the guidelines state at this stage that the process should be repeated 5 weeks later if the person is stable in the meantime. This is something on the last masterclass we did have some discussion regarding, because we know in some situations clinicians do actually bypass this stage and do prescribe based on the initial assessment. So for example, if a patient is very hypoxemic at this stage, then it wouldn't be sensible to send them away for 5 weeks before you carry out another gas. Okay, so obviously once they're in the specialist clinic, and you may well at this stage have decided that they need some oxygen. So if you take their blood gases and their PaO2 is still below 7.3 or 8, as discussed in the previous criteria, we would need to give them some oxygen in the clinic situation. So dependent on their saturations, probably this will be given at 1 or 2 litres per minute. But again, at this stage in the clinic, you are looking at their saturations to make sure these are increasing with the oxygen in situ. You would then repeat their arterial blood gases, and obviously what you're aiming for is a PaO2 of above 8 kilopascals. If you don't have this at this stage, then you would need to increase their FiO2 and repeat the process until the hypoxemia is corrected. Obviously, at this stage, you will also be wanting to look at the patient's CO2 to make sure they are not becoming hypercapnic. Considerations when carrying out this assessment: it is best managed in a clinic setting where possible. We know that there are some situations where this is being carried out at home, but obviously that's more complex than carrying out in a clinic. The assessments on oxygen should be carried out on the equipment intended to be supplied, and obviously with the new contract we do now have many more different types of equipment which we can use. So it is important to test people on the equipment you intend to give them. And it is important, where possible, to have two assessments a few weeks apart when a patient is free of exacerbation, and not forgetting at each stage to make sure a patient has rested for 30 minutes before the gases are taken. And remembering, in a clinic situation, if a patient suddenly asks to use the bathroom or has had to walk a long way to the clinic room, then we need to make sure they've had adequate time to rest before saturations or gases are carried out. Obviously, clinicians involved in this process need to be competent to take an arterial sample, and you should have an arterial blood gas or capillary blood gas policy in place to back up your clinical practice. You're aiming within these clinics to make sure that your PaO2 is increased above 8 kilopascals without a subsequent increase in PaCO2. We also need to just consider smokers as well at this situation, because obviously we've mentioned this earlier in Julia's presentation as to the advice and education that needs to be given to smokers if you do prescribe oxygen. So we're going to talk through some case studies now. You don't obviously have to scribble any of this down, because I will refer back to the slide as we ask the questions. So this is your case study number 1. So Mr. Green is a 63-year-old gentleman with confirmed severe COPD, been referred to the clinic by the GP with saturations of around 91–92% on room air at rest, and it's been this level on 3 separate visits over the past 3 months, so we know that this has been going on for some time. Mr. Green has no significant other current or past medical history, and during this clinic visit his saturations are very similar to those that were referenced when referred by the GP, so between 90 and 91 on air following a 30-minute rest. Following that time, as typically happens, the patient, after you've asked them to rest for 30 minutes, asks to go to the toilet, which is approximately 15 metres away. And on return, you notice he is significantly short of breath, with saturations decreased to 84%. And it takes a good 5 minutes for those to return to his pre-exertion level. So at this stage, just to consider, what information would you decide that you would need to know about before you take an arterial blood gas? So just have a few minutes maybe to think about that, or discuss with any colleagues you're with currently. Okay, so just to move on, the types of things we were thinking of that you would need to check is, before you move on and take an arterial blood gas, you need to check that somebody's medication is optimised. You also need to make sure that they are free from exacerbation, so 5–6 weeks free of exacerbation. And you need to make sure, obviously, that they're not on any medication which would mean they're increased risk of bleeding if the arterial blood gas is taken. And obviously at this stage you want to know how much their current symptoms of shortness of breath are actually affecting them, because that will be important for the rest of your assessment. So you decide to take an arterial blood gas from this person, and these are the blood gases that you actually receive. So have a moment to look at those. So your pH is 7.4, your saturations are 91%, your carbon dioxide is 4.7, your PaO2 is 8, and your HCO3 is 24 with a base excess of 1. So just have a moment to look at those. And at this stage, what I'd like you to think about is, based on those results, does the patient require oxygen or not? So if you can, and you've had time to look, if you can answer yes or no before we move on to talk through how we would manage this patient. Okay, so we're getting some responses through already. We're getting a complete mixture of responses. We're getting lots of A's and lots of B's. So we'll move on to see what we would do. So the next question would be, what would your plan be based on the earlier question? So more than one of these answers may be correct. Would you leave them in status quo and review them or monitor their saturations in 4 weeks? Would you arrange an ambulatory oxygen assessment? Would you prescribe oxygen at 1 litre and monitor them? Or would you prescribe oxygen at 2 litres and monitor them? And again, I'll give you a few moments just to have a think about what you would do. Okay, so we're starting to get some answers through now. And again, we're getting quite a mixed response. So very mixed response is the feedback I'm getting from Rachel. So these are the answers we would consider to be correct. So we would leave them in status quo and with a view to reviewing them. And we would obviously arrange for them to have an ambulatory oxygen assessment. The key points here really from the case study and from the blood gases were that following asking the patient to rest, they went to the toilet and back and had a significant desaturation, which again took a long time to return to normal levels, which is why an ambulatory assessment would be necessary. Also from the arterial blood gases, they had a PaO2 of 8, which is above the criteria of 7.3. They didn't have any other comorbidities, which would mean that you would use the 8 kilopascal criteria. So in this case, just to summarise, we would leave them off oxygen, monitor the saturations and arrange a relatively urgent ambulatory oxygen assessment. When Julia moves on to her presentation, she will be discussing the same cases and therefore will go through the ambulatory assessment for this patient. So in this case, no hoof would need to be completed. So as I said, they had borderline hypoxemia with no CO2 retention. So, on to case 2. This is Mrs. White, a 69-year-old lady who has very severe airflow obstruction and advanced COPD. She's already on long-term oxygen therapy via a concentrator, which she's been on for a year, and she uses for approximately 15 hours per day at 2 litres per minute. At the time she was given her long-term oxygen, she refused ambulatory. She's returned to the Hosea clinic for her annual review. She's quite active. She walks her dog twice a day and attends Age Concern and goes out shopping with her son once a week. She's now finding this increasingly difficult and has asked us about having ambulatory oxygen. So following your assessment in the clinic and your review, you carry out her arterial blood gases on the 2 litres a minute, which is what she's currently receiving at home, and these are the results you get. So her pH is 7.4, her PaCO2 is 5.1, her saturations are 89%, her PaO2 is 7.6, and her HCO3 is 24 with a base excess of +2. So again, take a moment or two just to look at those results and decide what you think you might want to do with this lady. So again, thinking of those blood gases, does this patient require more oxygen than she's currently receiving at 2 litres per minute? So again, if you could respond with a yes or no answer, that would be great. Or an A or B is fine. So starting to get some results through now. Okay, so we've got some A's, some B's, some maybes. Again, a very mixed response. And again, what would your plan be with this person based on your earlier response? So would you increase the patient's oxygen to 4 litres per minute and review in 4 weeks? Would you increase their oxygen to 3 litres a minute, wait 30 minutes and retest in the clinic? Would you leave their oxygen the same and review their saturations in 4 weeks? So again, if you can answer A, B or C so we can see what your preferred plan of action would be. Okay, so we're getting, again, a mixed response, lots of B's coming through. So the correct answer here in our eyes is to increase the patient's oxygen to 3 litres per minute, wait 30 minutes in the clinic and retest today. So clearly from the initial blood gases, this person remained hypoxemic and therefore needed an increase in their oxygen. So that would be done again in this clinic appointment. So the patient remained hypoxemic, which was not being fully corrected by their long-term oxygen therapy. She did, however, have no CO2 retention, which means that you can safely increase her oxygen and repeat the blood gases. So that's exactly what we do, is we increase the long-term oxygen to 3 litres in the clinic and wait for 30 minutes, and we retest their arterial blood gases. And these are the results you have in your clinic. So again, take a moment to look at these results. So on 3 litres per minute, the pH is 7.4, PaCO2 is 5.4, PaO2 is 8.5 now, saturation's at 93%. So again, at this stage, what would you like to do? So your possible answers could be review the saturations in 4 weeks, refer for an ambulatory oxygen assessment, review the patient in 5 weeks' time, or prescribe 3 litres of oxygen via a concentrator. So again, type in your answers. Okay, so people are taking a while to think about this one. So again, we've got some coming through now. Appears to be a bit more agreement on the answer for this one. So those of you who typed in will see that you're quite correct. So you would prescribe 3 litres of oxygen via the concentrator, so increasing the oxygen amount, and refer for ambulatory oxygen assessment. So we know that this patient now would like some ambulatory. In terms of follow-up, she should be followed up via saturations in 4 weeks, and she should then have a 6-month review if her ABGs are stable. Okay. And of course, looking at the appropriate section of the new hoof, this wouldn't need to be filled in because you are changing the amount of oxygen required by the patient. So in this case, you may very well just continue with the same concentrator and increase the literage to 3 litres per minute. But this will depend on the result of the feedback from Julia's presentation regarding this patient's most suitable ambulatory prescription, as this may have an effect. Okay, case 3. Mr. Pink is a 78-year-old patient with interstitial lung disease, which has been diagnosed for a year. He's quite comfortable at rest, but he's been very limited on activity by shortness of breath. He's been referred to the clinic by his GP, asking whether the patient would be suitable for home oxygen. At rest, this patient's saturations are 93%. However, you ask him to walk down the corridor with you and you discover he becomes very distressed and short of breath quite rapidly, with saturations dropping to 78%. So back to our questions. Do you think this patient requires long-term oxygen therapy? Please type in your answers. So we've got some people doing very well with their answers. Give you slightly more time, just a few more of you to input some answers if you wish. Okay, and again, based on your answer, what would be your plan? So would you like to review the patient in clinic in 4 weeks? Would you review saturations in 4 weeks at home? Would you take blood gases or would you refer on for an urgent ambulatory assessment? And some of you are really quick at your decision making, but for those of you who are not quite so quick, you can have time to input your answers now. And that's, everyone is agreeing on this one, so let's hope it's the same answer as we have. So again, this is somebody who most of you acknowledged you would need to refer for an urgent ambulatory assessment, which again Julia will go into detail. This patient would also benefit from a saturation check at home, so if you do have a specialist team or facilities to do that in 4 weeks' time, that would be very useful. So refer on for an urgent ambulatory assessment and monitor at home. This patient may well need a review sooner than that in a clinic, and so that's something that will have to be judged as time goes on. Okay, and you'll be pleased to know your final case is Mrs. Black. She's a 59-year-old with confirmed severe COPD. She's been recently discharged from hospital a couple of days ago and had been prescribed long-term oxygen therapy at 2 litres a minute. And she's been using it basically all of the time, 24 hours a day, and it was prescribed by secondary care. She needs an urgent review and is sent to the clinic for that reason, because she's become very sleepy in the day and she's been waking up with headaches. Saturations today are 93% on the 2 litres a minute, which she's currently receiving, and that's following the following the 30-minute rest. So you've obviously assessed her and talked through your subjective and looked at your objective assessment. You perform an arterial blood gas on the 2 litres, and these are your results. So the pH is 7.39, PaCO2 6.9, PaO2 is 8.7, saturation is 92%. And your bicarb is 32 with a base excess of +3. So your question this time is it safe for this patient to have this much oxygen? Okay, so I'm glad we're getting some agreement on this issue. Okay, so again, based on that answer, what would you do? Would you remove the oxygen and reassess the saturations at home in a week? Would you reduce the oxygen to 1 litre and repeat your ABGs? Or would you maintain the oxygen at the current level but warn them of the side effects of CO2 retention? Again, if you pop in your answer. And again, many of you answering B for this one. So what we would suggest is that you reduce the oxygen, because if you remember she was on 2 litres from her discharge, reduce it to 1 litre and repeat the arterial blood gases just to see if that makes a difference to her hypercapnia. We know that she was retaining CO2 because her PCO2 was high, so it's unsafe to persist with 2 litres per minute. She also had classic symptoms of CO2 retention in that she was very sleepy during the day and was having headaches when she was waking up. So you reduce CO2 to 1 litre and you repeat the arterial blood gases, and these are the results you get. pH 7.4, PaCO2 6.5, PaO2 8.3, saturation is 91, and HCO3 32 with a base excess of +3. So probably not the results most of us would have been hoping for, based on a reduction of her O2 to 1 litre. So what do we do at this stage? Any suggestions? Are people happy with those blood gases on 1 litre? Oh, we're getting lots of very detailed answers as to what to do, which is quite nice to see. Okay, so as you saw with this example, the patient with those blood gases, despite the reduction to 1 litre, still had CO2 retention. This may be a very good candidate for an NIV assessment. So that's definitely something which should be considered. they would need referral for an ambulatory oxygen assessment, which again Julie will go into detail on. And in the interim, we would suggest at this stage a reduction in the LTOT to at least a litre in the interim to see how the patient fares following that. We did have some suggestions of reducing to 0.5 of a litre and redoing, which I think is a perfectly sensible other option. But again, it might depend on how many blood gases you've taken, whether you're using arterial or capillary, and whether the patient is happy to sit for a further 30 minutes and have another blood gas taken. Okay, well done. So on that patient, remember you are again changing the dosage of your oxygen, so you would need to fill in a hoof. And again, this highlights the new hoof and the part you would need to fill in. So you would need to reduce to a litre now and resend off your hoof in the interim. So well done for those of you, and thank you for being so interactive for those of you who have been. Just to highlight some further points, just to make sure these are remembered with your LTOT assessment, is to make sure a clear diagnosis is apparent and you have up-to-date spirometry. Make sure their saturations are above 92%. If not, then they should be referred for assessment. If they have borderline saturations between 92 and 95%, monitor them and perhaps get them referred back to clinic if things drop below 92%. If they're clearly above 95, then refer back to the referrer, stating that they don't at this stage need oxygen. Patients should have follow-up saturations checked at home if possible, 4 weeks following a new prescription of oxygen, and thereafter 6 monthly saturation checks and annual arterial blood gases. Remembering again a point that was highlighted earlier as per recommendation 61 of NICE, that to get the full benefits, patients should breathe supplementary oxygen for at least 15 hours a day, and we know as per the research that greater benefits are received for patients who actually have over 20 hours per day. Thank you very much for listening to my section. I will just check if there are any additional questions before we hand over to the next section. Okay. I'm just looking at the questions now. Okay, so one question we've had through is related to palliative care patients, so where patients have been deemed palliative and are hypoxemic but are not up to coming to clinic appointments, and I think we would all agree that for these types of patients they shouldn't be put through an invasive procedure and shouldn't be brought up to clinic. In this situation, in my experience, pulse oximetry is the preferred method, and this can be used obviously in the home setting to avoid unnecessary distress for patients. Okay, another question. I'm just having a look at this just for clarification. Yeah, so we had a question about if you were given half a litre of oxygen, what kind of mask would you use? That would obviously be via nasal specs to do that. Many concentrators now will go down to 0.5 of a litre, and there isn't a mask that will do that, so we would advise nasal specs via a concentrator. And remember, we did mention at the beginning of this session that during your assessments you should be using the equipment which you are aiming to prescribe the patient. Just taking a couple of other questions. So someone's asked what is an NIV assessment, so we're talking about an assessment for non-invasive ventilation here. So that will in most cases be done in the acute setting via, I'm going to hand over actually for that one because I'm getting lots of people waving arms at me for this one who are obviously eager to answer this question, so I shall hand over to Jo to answer this question.
sorry, Kath. So you're perfectly capable of answering that, and we were waving frantically behind. So really, this is a question about whether someone would benefit from nocturnal home non-invasive ventilation. And in our region, there are some centres regionally do that. In Kent at Ashford, Dr. Pratheba does those kind of assessments. Most other places, the respiratory teams would do the initial assessment and then refer on to one of the London centres if they felt it was appropriate for the patient. The two are the Lane Fox at St Thomas's or the team at the Brompton Hospital. But it's worth having a chat to the patient about what it would entail, so they understand what they might be planning. But people do get symptomatic benefit from it. People are often put off by the thought of having a mask overnight, but my experience, people who actually get symptomatic benefit will put up with this because of the rewards.
Thank you, Jo. That was much easier than trying to understand the sign language that was coming at me from behind. Okay, we've got a couple of other questions. I had one here from somebody I know very well who has asked me whether somebody with variable saturations between 87 and 95% at rest, and what do you do in that situation where, obviously, I presume what you're implying is that you may well bring them into clinic and get the saturation above the 92, and I think that is very realistic and happens quite a lot and is quite difficult to deal with. I think you obviously have to try to get them on a day when they're at their best and th're well, and I think you have to make a decision on that day, which I know may not be very, might not make the patient very happy in that they might be sent away without a blood gas. But I think if they are kind of borderline, sort of around 91, 92, 93, and the patient is struggling with shortness of breath, then you have to make a decision perhaps at that stage to take a blood gas and to see what it's showing you, because we know that obviously saturations are not quite as accurate as taking a blood gas.
We hope you enjoyed session 3 of the Oxygen Masterclass. Sessions 1, 2 and 4 are also available. These will cover respiratory failure, risks and dangers of oxygen, and the ambulatory oxygen assessment.